So our last speaker is again going to be a virtual speaker, and again on sensors, and that's Professor Bijan Najafi, who is at Baylor College, professor there in the Department of Surgery, and he's Director of Clinical Research in the Division of Vascular Surgery. He will tell you about the work that he's been doing in various devices to reduce the risk of pressure ulceration or foot ulceration.
Ladies and gentlemen, good morning and good day. Greeting from Houston, Texas. I'm so grateful to have the opportunity to speak at the 18th Malvern Diabetic Foot Conference. Unfortunately, because of the pandemic, I miss the opportunity to present this talk in person, but I'm looking forward to interact virtually with all of you and exchange our knowledge, and hopefully looking forward to see you all next year. As a short introduction about myself, I'm Bijan Najafi. I'm currently serving as a professor of surgery and director of clinical research at the Division of Vascular Surgery and Endovascular Therapy at Baylor College of Medicine in Houston, Texas. By training, I'm an engineer, and my expertise is in area of digital health, wearable technology, and remote patient monitoring. That's perfectly in line of the title of my talk, which is Health Sensors, Smart Home Devices, and Internet of Things, Opportunity for Foot Care. This is the list of my disclosure. I don't have any financial conflict of interest. So during the next 30 minutes or so, I will overview some of the recent research, including research from my team, which are focused on the application of technologies and more specifically digital health to improve the health, well-being, and healing of our patients with diabetic foot ulcer. Ladies and gentlemen, as you know, unfortunately, despite many progress in the field, still we are losing too many limbs because of diabetes. More specifically, every 1.2 seconds, somebody around the world develops a foot ulcer, and every 20 seconds, somebody losing a limb because of it. The time's up, and we need to find a better solution to promote prevention of foot ulcer and its associated consequences like limb amputation. On the other hand, consumer electronics and related technology are increasingly being integrated in every aspect of our lives, representing an opportunity for creative solution to prevent this devastating condition or promote ulcer-free days. Some early results support the benefit of technology, such as smart socks, Internet of Things, and smart home environment to promote prevention and diabetic foot ulcer. While these technologies are still in infancy, I believe the COVID-19 pandemic could accelerate the adoption of this technology at a scale. More specifically, this pandemic shows that traditional home care delivery models that here on the screen you see on the left side, the center on the hospital, is not at a scale to handle situations like the global COVID-19 crisis. For instance, for a case of diabetes patient, people with diabetic foot represent a fragile population. Therefore, they have been urged to avoid unnecessary hospital admissions and outpatient visits to reduce their exposure risk to COVID-19. This has disrupted the best practices for preventing disease-related complications. In response, many healthcare providers, I'm sure including you, are re-engineering their pathway to promote care in place. Care in place model that show here on the right side of your screen, actually it's now becoming the foreground in governance practice to decentralize care delivery and reduce care disparity, particularly for people not living in city populations or living in disadvantaged zip code areas. Thanks to connected technologies, new solutions now have emerged that have significant potential to address some of the current healthcare system challenges, and most importantly, can improve even overall outcome and also reduce financial burden on the public health. So here, in the rest of my talk, I would like to give a couple of examples on the three major categories of care in place. One is in related technologies that help to triage those who need to see in clinic for face-to-face visit. And the second one are technologies that actually help to empower patients. And finally, the third category that I will try to explain, give a few examples, are related to remote care delivery. To look at the triaging, by definition, triaging is the process of deciding how seriously ill or injured a person is, so the most serious cases can be treated first. Triaging can be beneficial for both prevention and intervention. So let's overview a couple of examples from the recent technology. So if you look at for the case of diabetic foot, traditionally, as it's shown on the left side, we are seeing patient, or we are scheduling regular visit for patient in clinic based on some of the in-clinic assessment that we are doing in clinic. For instance, if somebody is classified at a low risk, we schedule them on an annual basis, and then we can change this time frame on even 1 to 2 months or immediate scheduling. But these regular scheduling can easily overburden healthcare system. Even these kind of the personalization recently suggested by David Armstrong and a colleague, it can miss some of the cases that need to urgently seen in clinic. For instance, even in specialty diabetes centers with dedicated staff and top shelf resources, the current model of regular visits is still associated with very high reoccurrence rate. We believe that we need to start adopting the right side of the model of care, that is decentralized care. Recent advances in particular remote patient monitoring and advancing in artificial intelligence now can detect risk of diabetic foot ulcer with high sensitivity and specificity. These offer the potential for remote triage of patients and enhanced monitoring procedures. So in the case of prevention, everybody knows that if you would like to prevent an amputation, everything starts from inflammation. So if we achieve to actually prevent inflammation or detect early sign of inflammation, maybe we can be able to provide timely care, triaging the patient, bring them to clinic, and prevent incident of foot ulcer. So because inflammation is the earlier sign of ulceration, the technology that can capture inflammation may assist in predicting diabetic foot ulcer with sufficient lead time. There are 5 signs associated with inflammation, including dolor or pain, calor or heat, redness, swelling, and loss of function. However, among of those measurements, because of neuropathy, the patient, they don't feel pain, they are usually inactive, so the pain and loss of function are not good. At the same time, many of those patients has edema, so swelling and redness may not work. So currently, the most reliable measurements for identifying inflammation is the measurement of the heat. The rationale for measuring plantar temperature is built on the notion that the skin heats up before it breaks down into ulcer. Isolated plantar region displaying increasing heat is mainly due to inflammation response of near damage or damaged tissue. Originally was suggested by late Paul Brands, and I'm sure that everybody knows that, back to 1972. They suggested this technique as a better way to prevent diabetic foot ulcer and identify the high-risk patient. However, it took almost 2 decades that finally the group of David Armstrong and all, back in 1997, they proposed the use of portable handheld infrared skin temperature probe as an effective technique to predict foot injury as well as food complication because of Charcot. Later on in 2002, Dr. Lowry and colleagues in series of randomized controlled trials, they demonstrated that using thermography as a self-assessment tool is effective to prevent reoccurrence of diabetic foot ulcer, specifically 10-fold reduction in incident of diabetic foot ulcer. Despite of low cost and in simplicity and even recent development on the app to measure thermography, still regular skin temperature is not as a part of the care for management of diabetic foot ulcer. That might be because some of the complication of this tool that I will explain in a minute. For instance, some patient may not be able to easily interpret the difference of temperature between two spots. The current method, we need to measure the temperature on right foot and left foot and seeing that whether the temperature increasing from 2 degrees centigrade. That may perceive easy, but actually it could be complicated for some of the patient. To address these gaps, Dr. Freiberg and colleague, including also my team that contributed in this project, they used a smart mat based off telehealth concept that can address the limitation of the previous thermography tools. Specifically, what we studied, it was a novel in-home connected foot mat that developed by a company named Podometrics in Massachusetts to predict prospective incidence of diabetic foot ulcer, to better stratify those who need urgent foot care. This simple to use system was designed to require no configuration or setup by the users, who simply stand or step on the mat with 2 feet for 20 seconds. Using an embedded cellular component, connected data or stream to cloud, so there is no need to have Wi-Fi or smartphone, that maybe some of those patients may not have it. Then using image processing, an integrated program, the temperature profile of the feet is captured. In their study, they find out that if they look at the threshold of the 22 degrees centigrade between corresponding sides on opposite feet, we can correctly predict 97% of diabetic foot ulcer with an average lead time of 37 days. Adherence to the mat was good, was estimated to be 86% in participants using the mat for at least 3 times per week and an average use of 5 times per week. While the accuracy and lead time could be sufficient to better target those who need urgent care, the technology suffers from an important limitation. Basically, while 2.22 degree centigrade provide 97% sensitivity, it has a poor specificity or high false alert. But despite of that limitation, this 73 days lead time could be promising for effective triaging and coaching the individual or their caregivers to alter behavior to reduce the diabetic foot ulcer. To maybe increasing the specificity or reducing false alerts, one another way is that not just relying on foot temperature, also measuring other metrics like the pressure that's shown to be also a good predictor of diabetic foot ulcer. So this is a technology that we developed a few years back. We call it the Smart Socks. The Smart Socks was based on fiber optic, not only measure temperature in continuous way, also is measure some other metrics like pressure and also joint angle, and provide a simple interface to guide that which location of the feet might be at a high risk and how we should triage urgency the patient in the clinic. We validated this concept against of gold standard. However, its clinical validation to demonstrate that it's effective to predict diabetic foot ulcer or prevent diabetic foot ulcer still remain to be assessed. But there are, it seems, some technology that using similar concept and show promising results as well. Triaging, of course, is not just limited to prevention of diabetic foot ulcer. Recent development in mobile health also provides a good way of triaging of the patient who need to seen by a specialist like vascular surgeon or the patient that maybe they are easy to heal wound. This is, for instance, the app that actually developed by Society for Vascular Surgery and incorporate the Wi-Fi classification. The concept is based of entering three different categories of information. One information about the wounds or a simple questions that they address, and you can enter your information in the app. The other category is about ischemia that you can measure using three different categories, including ABI, toe pressure, ankle systolic pressure. And the last one is some questions about infection. And then the app will generate a score, a Wi-Fi score, and actually it's give some recommendation for referral, whether, for example, the patient can benefit from referral vascular surgery. The idea of those apps is making timely triaging and making smart referral to specialty care. AI has a very great contribution in this field. This is great work done by University of Manchester by Dr. Bolton and team that will present in the malware meeting. It's based on the AI and a simple photography of the wounds. We can characterize the wounds and extract the information like area, color, texture, shape. And based on a machine learning, an AI actually is generate an index to identify how hard it is to heal the wound. And then you can make a decision making that whether we should make a referral or using more advanced therapy for that aspect. Still in infancy, but with the fast development of AI, I believe the great actually opportunity for these concept and technology. So the next category that I would like to cover about it is empowerment. By definition, the empowerment means the act of giving somebody more control over their own life or the situation they are in. So if you look at again the traditional model of the care delivery in past, as you see on the left side, usually we consider the patient as a passive recipient of the care. This model has led to an inherent tendency to blame the patient for not having compliance and being deviant of the protocol of the care. But in the new model of the care delivery, we would like to consider patient as active engagement and active role in the care ecosystem. And the technology now can facilitate that. You can decide that how much the care responsibility you want to deliver to the patient hands, and having not some tools to control that whether the patient actually act on those care management. The empowerment, of course, is very complicated. It's not very easy that you're saying that just I would like that the patient doing that part of the job. First of all, you need to consider the three major components of the empowerment. The first, of course, is empowerment. You need to decide that actually how much care you would like to put in hand of the patient. This is what we're calling as empowerment. Then you need to have the activation. Activation means providing the necessary tools for the patient to take that responsibility, providing the needed education, and also ensuring the early days of intervention the patient follow the recommendation. But their job is not finished at the level of activation. Then we need to have engagement. Keep in mind this process is a very long process. So we need to have a solution to ensure that the patient continue to be engaged as a part of the care delivery. And all of them, they are well connected to each other. So for instance, if in the area of the empowerment, what you are asking the patient is too much, like the case of the temperature monitoring, we are asking maybe too much of the patient. Naturally, giving that control on the hands of the patient may not be very effective. Or if you don't have a good solution to monitor adherence to that empowerment, or you don't have gamification aspect to manage engagement, ultimately the empowerment plan could be completely failed. There are some good studies are coming from empowerment. These studies coming from actually Dr. Reeves, Andrew Bolton and team from University of Manchester and Metropolitan Manchester. They use the concept of smartwatch and smart insole. The way that they provide empowerment is that they put in the hand of the patient to identify harmful physical activity, like prolonged standing. I'm standing in front of the camera and may not realize that I put pressure on my feet for quite a long time. That could be risky for the patient. And through the watch, they alert the patient when they have this kind of incident that represent the high pressure. They follow, actually, they recruited 90 patients with history of foot ulcer, and they follow them for 18 months. And they demonstrate that way of empowerment is effective to prevent ulcer reoccurrence. Most specifically based on their data, they observed 71% reduction in ulcer reoccurrence. Of course, we should pay attention that there are some challenging things on activation or engagement. For instance, it seems that we have a significant dropout on the patient, specifically 35% dropout. So maybe interpretation of those results should be cautious, but in any way, is a great step forward to demonstrate that empowerment is working. We can finally deliver some of the care tasks to the patient. There are also some technology that use the concept of empowerment. For example, this is smart socks developed by a company named Siren Care. They use actually a smartphone to guide patient, empower them to take care of the sign of inflammation and doing the management. They also use a third party like nurse as interface between patient and doctor to improve engagement. They publish a paper to show that accuracy of this system, but to my knowledge, yet the clinical validation of this concept for prevention of the foot ulcer remains to be studied. So we recently actually got an R1 grant from National Institute of Health. This is a joint collaboration between David Armstrong and my team at Telemedicine and University of Southern California. We thought that maybe we can also empower patients to be involved in offloading process and improving the adherence to the offloading process, as well as controlling the dosage of allowable physical activity. How the system is work, we are using a standard offloading. Only thing that we do, we added a sensor on top of that offloading. This sensor detects that whether the patient wearing the offloading or not when they are walking. Also through the smartwatch, we transfer data to the cloud to build a patient portal that through the patient portal, the nurse, the doctors can see and triage patient who doesn't have a good compliance. And then they can call in patient to reinforce adherence. Another also interesting point that we have and we're working on it is how many walking the patient are walking with boot or without boot. Even with boot, we did a prior study that we demonstrate that maybe depend on the patient, a patient that even has perfect offloading, maybe a level of physical activity should be limited. So providing some control on number of steps done per day could be very interesting. This is an ongoing study, but just I would like to give you some example of different components that we'll talk about it here. The concept of empowerment is monitoring adherence to offloading and acceptable dosage of physical activity. The activation component is providing a smartwatch to all individuals, very low cost in a smartwatch, and also providing some simple notification, even encouragement. We have happy face as well as a part of this empowerment to ensure that we have activation, the patient receive education, and also continue engagement. For engagement, we have real-time alerts if they have not good compliance, and also some active and also engagement from the nursing as well. Now, the last category I would like to talk about is remote care. Again, pandemic, despite of many challenges that cause in many healthcare system, maybe they have some positivity, and that positivity is really promoting remote care. Originally, remote care was a little skeptical. We didn't have resource implementation, but now we are seeing that the doctors become used to it, the patient become used to it, and also now there are many industries that are working on this field. The remote care can start from a simple telemedicine. It could be using a smartphone to have FaceTime, just text message, to also having connected device to collect some additional information of the patient. It could be as simple as heart rate, EKG, respiration rate, or continuous glucose monitoring, or other metrics like foot temperature, pressure, etc. Even some other information like depression, sleep quality, etc. So all of those information can be collected that when you're doing telemedicine, you can provide more personalized care to the patient. Even there are some good development about care coordination, that if there are several people engaged as a part of the care, they can control that whether the predefined task has been met, what needs to be done with the patient, and coordinate the care between caregivers. In point of view of telemedicine for wound care, there are great studies that demonstrate that those studies are effective. It can help to cut the number of needed visits in clinic. For instance, on the left side, I show a summary of the results coming from great study of Ramsen and colleagues published in Diabetes Care back to 2014. They simply demonstrate that if we provide consultation to the wound care over telemedicine, we can cut the number of visits in clinic by 2/3, and it's still getting the same outcomes for wound healing, like wound healing as well as amputation, compared to when we are seeing the patient all the time in clinic. In the follow-up study, the same thing demonstrated that this solution is cost-effective and even reduce the cost on average by 41%. In point of reliability, because sometimes they are skeptical that whether if I'm seeing the wound image by a photo, whether I can still do a good decision making. There's a great study from University of Manchester by Bowling and colleague that demonstrate that if a clinician seeing the wound over picture and making the decision making compared to clinician that actually seeing the same wound, they have a strong agreement for decision making. There are some small exception in point of view of decision making for debridement or identifying the moistness of the wound that often by image might be tricky. But of course, for advances of the photography, and as I mentioned, AI, maybe we can also resolve those kind of the problem and providing better guidance to doctors for decision making based off the picture. Also, there are some promising data. Remember, I mentioned about the app that we can measure some physiological information from the patient or some questionnaires to improve the telemedicine experience. There are also some smart wound dressing that is coming that can provide a specific information for the wound healing, like monitoring pH, glucose level, moistness. So imagine that if we have this device combined with the consultation, we can provide still a good decision making and triaging the patient who need to see in the clinic or continue the care at home. There are also other development that's coming for remote care. For one of them is exercise. We know that exercise is the best medication, but it's very challenging to engage patient in exercise. In particular, patient with diabetic foot, we know that they are losing the muscle lower extremity during wound healing. As a part of recovery, we need to help them to regain muscles, to improve the biomechanics and prevent ulcer reoccurrence. But bring this patient to clinic for exercise, it could be very time-consuming, very costly, and might not be acceptable for patient. And if you rely the patient to do exercise at home, maybe they are not doing that. So to resolve this problem, this is a technology that recently developed. We call it Telexer or Telewise. So how it works, it's simply we place the foot, we attach a sensor on the foot, so the foot acts like a joystick. So you can play a game by movement of your feet. And we know that foot and ankle exercise is the best exercise for wound healing and recovering the muscle lower extremity. Here, there's just a couple of games that I show here. This is a space shooter game. So simply by moving the foot on medial-lateral direction, they can navigate, it's small here, but they can navigate a space shooter on the left and right. And when they want to hit a target, they should quickly do dorsiflexion, plantar flexion, and then they can hit it. So that concept we demonstrate them is effective to improve significantly blood flow to lower extremity and activate the muscles. Here I place a tablet here. I don't know that you can see here, but there is an EMG signal that actually it shows that how well we can activate the gastrocnemic muscles. Probably you see the sensor that attach on the muscles. These are EMG sensor. So they are very effective to activate the muscles, and also it's very fun for the patient to engage in exercise. The tablet, the only things that require the tablet sensor, all of them are wireless. The tablet also has telemedicine, and also remotely the doctor can monitor the exercise. Of course, there are a variety of the games. It's a flying bird. It's the same game, but just by dorsiflexion, plantar flexion, the flying bird is going up or down to cross a certain obstacles. You can adding the same game by asking the patient to, for example, pedaling a bike. When they are pedaling very fast, the bird is going up, and when they stop pedaling, the bird going slowly down, or it's pedaling on reverse. the birth is coming down. So I personally believe that maybe these remote care can be deployed and those kind of intervention can be implemented to promote the health and well-being of our patient. So as a conclusion, these are the key takeaway points that I tried to cover during my talk. I believe that healthcare is undergoing a technology transformation. Recent advances in digital health technology enable to triage high-risk patients who may benefit from in-clinic visit or telemedicine. And also, while they're in infancy, I believe that the development of technology, including wearable technology, can help to improve the self-knowledge as well as promoting the self-care, and telemedicine for wound care can be the next. Thank you so much for your attention. You can see here my email. You can see my contact information, Twitter. Please feel free to reach out to me if you have any questions. It's a pleasure being with you, and I'm hoping that this talk it helped to shed light on some of the innovation and technology. Please stay well, and hoping to see you all hopefully next year. Thank you so much.